Sir, we are live now.
Okay. Thank you, Chitrakala. Ma'am, with your permission, shall I start?
Yeah, please.
Yeah. Thank you, ma'am. Good evening, doctors. This is Dr. Someshwar from Shield Healthcare. I welcome you all on behalf of Shield. Thank you very much for joining today's webinar. I request all the delegates, please do comment your queries in the comment box so that at the end of the webinar, we'll have a short Q&A session. So now let me welcome our today's eminent speaker, Dr. Shilpa Reddy ma'am, who is a fellowship in advanced obs and gynecology and ultrasound specialist done at Mediscan at Chennai. And she's a consultant at Lakshmi Kishore Hospital, Produttur. And today's webinar is streamed through the Shield Connect, which is a digital platform of Shield. I request all the delegates, if you miss any part of this program, it will be available in the Shield Connect webpage. And coming to the today's topic, Incretin new pharmacological target in obese PCOS. So now, without wasting much time, let me turn over the time to Dr. Shilpa Reddy ma'am to talk on Incretin new pharmacological target in obese PCOS. Over to you, ma'am.
Thank you, sir. Good evening, everybody. First of all, thank you, Sheil, for giving me this opportunity. I would like to say I accepted this topic because, I was like, what is this Incretin? Have I become outdated? We are not using in obstetrics. So let me just know about it. Let me learn about it. So that's why I accepted this topic. So now coming to the main topic. So PCOS, it's a very common condition, and it affects 6 to 15% of the reproductive age group and 6 to 18% of the adolescent girls. So it's a complex etiology. It is mainly by it's a two-hit condition by two-hit hypothesis. So what is the first hit? It is the intrauterine. The first hit occurs intrauterine when the fetus is mainly subjected to heritable traits, and also because of disturbed maternal nutrition and fetal nutrition. So that is the first hit occurring, and the second hit, it occurs after birth. That is mainly because of the postnatal nutrition, the childhood obesity, the nutrition and the activity which occurs during the growing up ages of the child. So it's like it's like a cycle, and here we can see that mainly the CNS program in utero, the CNS programming and the genetic and epigenetic changes occur, and during adrenarche, the child is exposed to a lot of to the inflammatory factors occurring, especially in form of all the junk food which children are eating and the environmental exposures, and also lack of exercise and activity and hormonal exposure, which is mainly occurring because of various adulterants, like children taking milk, which is nowadays they are giving oxytocin injections to the cows to increase milk production. All this leads to excessive ectopic fat storage, and this leads to the androgen excess, and this androgen excess, it activates the ovarian factors and leads to insulin sensitivity, decreased insulin sensitivity, and so the woman again, she develops the PCOS phenotype, and then she develops then she becomes pregnant, and again the whole scenario occurs. So what is the mainstay of PCOS treatment? It is the obesity management. So the first treatment, the first thing which should be concentrated is diet. It should not be like, okay, you do dieting and you tell her lose weight. It's not sufficient. You have to sit with the patient. You have to talk to her. What are her food preferences? What are her eating habits? And in what way can you help her? You have to tell her, you have to educate her regarding what are saturated fats and what are unsaturated fats, what are complex carbohydrates, and what are, and in what way, we can help her, what is Mediterranean diet. And because as soon as you tell them you reduce weight, they'll Google up, and in YouTube they'll be like, so many stuff like lose weight in 3 months, you lose 30 kgs, and all kind of nonsense, which really doesn't happen. So you educate the patient regarding diet and exercise. Exercise, it again, it should be a modest exercise which he can practice. Like, most of the women, you have to tell them, like, they might have inhibitions regarding joining gym, or affordability to go join yoga classes, etc. So the first and foremost thing you have to encourage the woman is, you have to tell her, do walking. And walking should be like, first you should encourage her, like, you walk anyway, you climb stairs, yeah, anyway you have to go, try walking instead of taking auto, or by going by automobile. Bariatric surgery can be considered for the very obese patients, and but as such, pharmacological treatment for weight loss and bariatric surgery is not routinely recommended for ovulation. The first line of therapy is is weight loss in obese women with PCOS. So what are the current recommendations for lifestyle? First of all, any lifestyle modification, it should be taught to the patient that it is not one day phenomenon. It has to go on lifelong. It should not be like, okay, as soon as you achieve your pregnancy, you can forget everything and again come back to your normal status. You have to tell her this is a condition where she has to be constantly motivated till her death. That should be put into her mind. And weight loss should be aimed at 7% of body weight. And physical exercise, increase physical exercise at least 150 minutes per week. Initially, a calorie diet should be planned in such a way that it is less by 500 to 1000 calories from the usual diet. You should tell her, educate her, like, to increase more green vegetables in her diet, to take fibrous green leafy vegetables, which are very effective in reducing weight. You should aim at 1 to 2 pound weight loss per week. The diet should be planned at a low calorie diet at 1000 to 1200 calories. Initially, when the patient is put on a low caloric diet of 1000 to 1200 calories, initially the weight loss will occur in the first 2 months or 3 months. But afterwards, the body becomes efficient, and it gets adjusted to even to this low calorie diet, and it starts, and then the weight loss becomes stagnant. So you should tell, then what happens, the girl or the lady tells, now despite of eating such a low calorie diet, I lost weight initially, but afterwards I'm not losing, so what to do? So what happens is, because of the disappointment, they again go back to their own eating style. So the constant encouragement and constant education regarding healthy lifestyle is the main focus of PCOS management. Then achieving total target should be achieving a total 10% decrease in body weight over 6 months. It's been shown that reduction of weight up to 5 to 10% of initial body weight may reduce the level of insulin and androgen. Weight gain reoccurs when lifestyle modifications are not sustained. So it's been shown that weight loss, you have to put in all efforts, that is lifestyle modification, dietary restriction, physical activity. Pharmacotherapy has been tried with varied results. Dietary interventions are associated with increasing weight regain over time. Although this can be minimized with continuing care, only 15% of the subjects can sustain weight loss successfully over the time. Rapid weight loss achieved by crash diets or excessive exercise is detrimental to the reproductive outcomes during fertility treatment. It's not only the reproductive outcome, there are many reports suggesting where the woman has, where the females have lost roughly around 300 pounds or 320 pounds in a duration of 2 years or 1.5 years. Some of them, they ended up with multi-organ dysfunctions, and they required ICU admissions and ventilations. So the rapid weight loss is never suggested. A modest weight loss, and throughout it should be properly continued for lifelong. Lifestyle modification, especially diet programs, have been associated with very poor levels of compliance, because very few people have that motivation that, to keep eating the same boring stuff, where, many people will say it's okay, it's only one day, you can have cheat day, one cheat day. Again, the cheat day becomes 2 cheat days in a week, and 3 cheat days. So lifestyle, especially the diet program, it's very difficult for compliance. A very low caloric diet resulting in rapid weight loss also impacts the oocyte quality and fertilization rates. So it's very essential that when the woman is undergoing rapid weight loss, put her on proper multivitamin supplement, so that oocyte quality and fertilization rates are not impacted. Metformin at a dose of 850 mg twice daily has not shown to have an improvement on menstrual frequency and body weight on long-term basis, despite of a fall in testosterone and waist circumference. Orlistat in obese PCOS has shown some degree of effectiveness. Orlistat is started at a dose of 120 mg per TID, and it's shown to show some weight loss in women. So Orlistat, it increases GI excretion of fat, and this GI excretion of fat, so it causes weight loss. But sometimes what happens is, the main side effect of Orlistat is increased fatty stools, but this fatty stool decreases over a period of time. Another side effect of Orlistat is that because of increased fat secretion in the stools, there is increased oxalate reabsorption into the body, and it can have renal problems. So metformin, it's the most commonly used drug, and it's the only drug which we are using from ages. Although there is some body of evidence, but it shows that there currently no use of using insulin sensitizing agents confirms a long-term benefit. Short-term benefit has been shown on insulin resistance and other cardiovascular risk markers. There is evidence that insulin may reduce androgen levels in PCOS patients, and modest reduction in weight reported by some women. Women with very high BMI, more than 37 kg per meter square, may not respond to standard metformin monotherapy alone. Lifestyle intervention was superior to metformin in improving cardiometabolic risk and progression to type 2 diabetes. Metformin can be considered in women who are already undergoing treatment and do not have improvement in impaired glucose tolerance, and women with impaired glucose tolerance. Metformin can be added in obese PCOS women in whom lifestyle interventions have failed. Other insulin sensitizers such as rosiglitazone, pioglitazone have been used, but they are associated with weight gain, and also some cardiovascular risk is seen. So we are not using it. Then comes the inositols. It's been seen that there is an insulin receptor which resides in the cell membrane, and insulin comes and binds to this cell receptor. It gets phosphorylated, and it secretes the insulin receptor substrates. Then P13K comes and docks to this insulin receptor substrates, and this leads to phosphorylation of phosphatidyl inositol. So myoinositol, it increases insulin action by making more phosphatidylate available. So it's been shown that myoinositol and D-chiroinositol levels are very low in PCOS patients compared to normal subjects. So there have been many studies comparing the beneficial effects of inositol. It's been shown that there is, after consumption of myoinositol over a period of time, there is a significant decrease in fasting insulin, significant decrease in homeostasis model. Sorry. Homeostasis model assessment, which uses fasting fasting blood glucose and insulin concentrations to calculate insulin sensitivity and beta cell function. So there's been seen a significant improvement in HOMA index and also a trend of reduction in free testosterone. There is a significant increase in sex hormone binding globulin after 24 weeks of treatment. So this leads to a reduction in testosterone levels. So there is definitely a role of myoinositol in improving the insulin profile in PCOS patients and also in improving hyperandrogenism. There is a role of bariatric surgery in the very obese woman. Again, while coming to bariatric surgery, caution should be taken that the woman should be properly counseled regarding bariatric surgery. The woman should be told that she should not become pregnant for at least 12 months after bariatric surgery. So here I would like to share one of my experience. There was a very obese lady. She with infertility problems, she consulted many doctors over the period of time, and everybody told her, you lose weight, you lose weight, and she found it impossible to lose weight. So she finally got bariatric surgery done. Then after bariatric surgery, she was told by the surgeon that not to become pregnant at least for 12 months after surgery, and she was advised contraception. But like most of the infertility patients, they are like, okay, what will I become pregnant? I didn't conceive in so many years. Why will I become in this first 2 months or first 3 months? So she ended up becoming pregnant at fourth month after her surgery. And though pregnancy continued, the baby ended up having cleft lip and cleft palate. Pregnancy was continued, but baby had to undergo surgery after birth, and baby is doing well now. So it is very important that after, if pregnancy occurs, pre and post operative nutritional deficiencies should be corrected. Then coming to statins. Usually statins are not recommended in PCOS patients, but statins can be considered if the woman is persistently having very high LDL levels, more than 190 despite of dietary and lifestyle modification, or higher than 160 mg per deciliter if there is a clinical history of familial hypercholesterolemia. So when the lady is put on statins, it should be done by a specialist. And she should be advised telling that statin should be stopped at least 3 months prior to becoming pregnant. So in such scenarios, the lady is put on statin and OCP together. It's been shown that statin and OCP together, they decline free testosterone level by 58%, whereas only OCP reduced free testosterone level by 35%. And statin plus OCP combination, there is an advantage of decreasing cholesterol and LDL levels. It's been additional benefit which has been seen by statin and OCP combination is a reduction in C-reactive protein. So whenever needed, statins can be combined with OCPs, but the woman should stop statin 3 months prior. In such cases, there is definitely a cardiovascular risk because of low, again, the woman might go back to increased lipid levels. So exercise should be advised and the woman should be encouraged to take Mediterranean diet. The current guidelines, they tell stop statin 3 months prior to become pregnant and during pregnancy and while breastfeeding. The women with PCOS should be when they are planning pregnancy, they should be put, or any woman should be put, if they are planning pregnancy, they should be substituted with 5 mg folic acid supplementation at least 1 month prior to conception, and folic acid should be continued during the first trimester of pregnancy. The obese women are again at a high risk of vitamin D deficiency. Vitamin D should be supplemented, but it's not only pharmacological vitamin D which should be substituted. The woman should be encouraged to go out, do outdoor activities and get plenty of sunlight. So this outdoor activities will help her in supplementing vitamin D and also in weight loss. So coming to the various potential target organs for therapeutic options in managing the metabolic aspects of PCOS, we'll start with SGL2 inhibitors. SGL2 inhibitors are sodium glucose co-transporter, and this prevents the reabsorption of glucose in the kidneys. So there is more glucose excreted, and the blood glucose level decreases. The side effect of this is because there is more glucose in urine, there is constant chances of UTI, and also there is a chance of lower genital tract infections. Then comes the insulin sensitizers. Most commonly used is metformin. This acts on the skeletal muscle, adipose tissue, and it decreases liver glucose production. Then comes imiglimin and statins. Imiglimin and statins, they act on the gut and they decrease fat absorption, and also they act on liver and decrease glucose production. Then comes orlistat, which again it acts on the gut, and also sibutaramine. Sibutaramine, what does it do? It acts on brain. It's a serotonin. It is a serotonin and norepinephrine reuptake inhibitor. So it leads to appetite suppression. It is mainly used in obesity and along with diet and exercise. But sibutaramine increases blood pressure, so it requires blood pressure monitoring. And also, in some cases, increase in heart rate has been seen. So this can lead to cardiac arrhythmias. So while the patient is on sibutaramine, BP requires monitoring, and also there are chances of increased cardiovascular events. So and again, the contraindications of sibutaramine are uncontrolled hypertension, hyperthyroidism. FDA has declared that some undeclared amounts of sibutaramine is seen in many dietary supplements. So it is advised caution while using these dietary supplements. Then comes the incretins. These incretins also, that is GLP-1 and DPP-4, these act on brain, liver, and gut. So what are incretin hormones? Incretins are glucagon-like peptide and glucose-dependent insulinotropic peptide. These are polypeptide gut hormones secreted from endocrine cells of small intestine under the influence of food intake and is responsible for 50 to 70% of postprandial insulin secretion. This is so-called incretin effect and is proportional to the current glycemia. It's been shown that after food consumption, the small intestine will secrete incretin hormones. So these incretin hormones, they act on alpha cell, and alpha cell, it acts on alpha cell and decreases glucagon production. So glucagon increases glucose. So since its production is decreased, there is a decreased glucose production. Then the incretin also acts on beta cell, and this leads to increased insulin release. This again leads to decreased glucose level. Incretins also act on the brain, the hypothalamic appetite center, and it causes suppression of appetite and gastric fullness. And also this incretin causes delayed stomach emptying. So again, these cause decreased appetite. Here we can see islet of Langerhans, and this orange color is alpha cell and this yellow color is beta cell. So this is normal cell and this is affected by type 2 diabetes. So here in healthy subjects we can see red and yellow, but here in type 2 diabetes we can see the beta cells are here in among the central mass. Here we can see the amyloid plaques. So the what happens here, alpha cell mass is maintained which secrete glucagon, whereas the beta cell mass, because here amyloid plaques have replaced the beta cell mass. So the overall there is a decrease in beta cell mass. So what happens in type 2 diabetes, alpha cells keep on secreting glucagon, whereas beta cells, because there is the function is decreased, so there is a decrease in insulin secretion. The major incretins are GLP-1, glucagon-like peptide 1, and glucose-dependent insulinotropic polypeptide GIP. So here coming to the comparison of GLP and GLP and glucose coming to the comparison of GLP and GIP, GLP is secreted by L cells, whereas GIP is secreted by the K cells. We can see that GLP concentration is decreased, secretion is decreased in type 2 diabetes, whereas it is not changed. GIP is not changed in type 2 diabetes. And GLP in type 2 diabetes, there is a inhibits glucagon secretion and reduces food intake and slows gastric emptying, whereas both GLP and GIP stimulate beta cell mass and promotes insulin biosynthesis. So GLP-1, it is a 30 amino acid. It is primarily secreted by ileum and it is stimulated by oral ingestion of nutrients, and it is metabolized by DPP4, and secretion is impaired in diabetes. So coming to glucagon-like peptide, what happens is, what are its various actions? Slows gastric emptying. Also, it suppresses glucagon secretion, enhances glucose-dependent insulin secretion, enhances beta cell proliferation, and all these lead to improved insulin sensitivity. So after a meal, there is an intestinal release of GLP-1, and in active it is activated. In the active form is 736. So what does the GLP-1 does? It inhibits glucagon secretion and also hepatic glucose production, and it increases insulin secretion, slows gastric emptying, and promotes satiety. So all these things, they lead to decrease in the glucose, blood glucose levels. What are the additional characteristics of GLP-1 based therapies? It reduces beta cell function, increases insulin biosynthesis, and also promotes beta cell differentiation. So this GLP-1 is very short acting, and it is deactivated by DPP-4. And DPP-4, it causes rapid inactivation more than 80%. And it inactivates into GLP-1 936. GLP-1 736 is the active form, and 936 is the inactive form, and this inactivation takes place by DPP-4. So initially, GLP-1 is secreted by ingestion of food. There is a beta cell response, and beta cell, what does it act on beta cell? It enhances glucose-dependent insulin secretion, and it also works to decrease the beta cell workload. The alpha cells, it acts on alpha cells and decreases glucagon secretion. It acts on liver, reduces hepatic glucose output, and it acts on stomach, helps to regulate gastric emptying, and also it acts on hypothalamus and promotes satiety and reduces appetite. So coming to the therapeutic potential of GLP-1, it has a very short T-half, less than 2 minutes, because it is rapidly degraded by DPP-4. So DPP-4 inhibition could lead to increase in GLP-1 half-life. What are incretin mimetics? Because GLP-1 has a very short half-life, incretin mimetics, they mimic many of the glucoregulatory effects of GLP-1 and are resistant to DPP-4, so they can be their effect can be long lasting. So coming to the GLP-1 receptor agonists in PCOS, the available data offer new opportunity to include GLP-1 receptor agonists in the management of PCOS patients who have not who have not responded to lifestyle modification with or without metformin. So there are 6 GLP-1 receptor agonists which have been approved, of which only liraglutide and exenatide have been studied in PCOS. Studies have been of short duration, and all have shown the expected effective weight reduction in GLP-1 receptors alone or in combination with metformin, and improvement in glucose parameters with variable results on gynec abnormalities and hyperandrogenism. So liraglutide has been studied in PCOS, and it's been shown that dose dependent effect on weight loss was observed, and in a dose of 3 mg, it is recently approved for weight loss management in many countries, but mostly it is with metformin, and after a month of 6 months treatment, patients lose around 6 kgs weight. Exenatide also has been evaluated in PCOS, and there was a randomized study of 24 weeks. It's been shown that mean weight loss of 3 kg with monotherapy alone in a dose of twice daily, and 6 kg in combination with metformin, and 1.6 kg with metformin alone. Combined therapy was superior to monotherapy, and there was improvement in menstrual frequency and ovulation rates. Insulin resistance and insulin sensitivity also improved. The total cholesterol levels also decreased with combined therapy. Weight reductions were seen, but achieved in a longer period of time, and there was a larger dropout rate. Here, I would like to mention these incretins are very costly, and maybe the larger dropout rate is one because of the because it is not a cheap option. It is very costly, and second thing because of the side effect profile, mainly because of nausea and vomiting, stomach pain. Maybe because of the side effect profile, and also and maybe in Indian scenario why we are not using incretins very commonly is because of the cost. Then comes DPP4 inhibitors in PCOS. The endogenous incretins are quickly degraded by DPP4 in serum, and so endogenous incretins degradation can be prevented by DPP4 inhibitors. They can be taken orally and are quite commonly used as anti-diabetic agents. They are readily available, but as incretin enhances insulin secretion in response to meal, DPP4 inhibition is not shown to cause hypoglycemia, and 5 DPP4 inhibitors are approved in the treatment of type 2 diabetes. That is allogliptin, sexagliptin, vidagliptin, and linagliptin. And the role of enhancement of endogenous GLP-1 with DPP4 inhibitors in treatment of obese PCOS is yet to be established. In contents, I have spoken to few endocrinologists regarding the DPP4, but who use DPP4s very commonly to treat diabetic patients. Their feedback is DPP4 does just maintains weight. It does not cause much weight loss. So various DPP4s have been studied: allogliptin, sitagliptin, saxagliptin, and so these have been shown to improve beta cell function and increase insulin sensitivity and also decreased insulin resistance. The chances of development of type 2 diabetes is decreased, and there has been less weight gain compared to lifestyle, and in combination with metformin there is a chance of less weight gain compared to metformin monotherapy. Agents mediating through GLP-1 effects in combination with lifestyle intervention and metformin could potentially improve treatment of obese PCOS via co-targeting multifactorial origin of obesity. Based on limited available data, GLP-1 receptor agonists, in particular liraglutide, should be considered in obese PCOS. Enhanced understanding of the impact of GLP-1 on weight reduction and metabolic effects metabolic effects on pituitary and ovary are expected in the next 5 years. Larger randomized studies are still needed to establish its effectiveness in reproductive and cardiovascular risk reduction. So I will just summarize with what are the current available novel therapies for management of metabolic aspects of PCOS. So coming to thiazolidinone, pioglitazone, it decreases hepatic gluconeogenesis and increases insulin sensitivity. The biguanides, especially the metformin, it decreases hepatic glucose production. Incretins, what do they cause? They decrease appetite, decrease gastric motility, decreases insulin resistance, decreased glucagon production, and they lead to weight loss. SGL2 inhibitors, they increase urinary glucose excretion and lead to weight loss. Statins, they improve the cholesterol profile. Oxidative phosphorylation inhibitors such as imiglimin, it decreases hepatic glucose production. Weight loss agents such as rimonabatin, it decreases appetite. Orlistat, it reduces cholesterol synthesis. Sibutaramine decreases appetite. Myo-inositol again increases insulin sensitivity. I would like to wind up telling, though we still the novel therapies such as Incretins, they have to be studied, and we have to know we hope that they'll become much cheaper and more available in the coming time. And but at present the only drugs available for metabolic for managing the metabolic aspect of PCOS is metformin and myo-inositol. Thank you.
Thank you very much, ma'am, for the wonderful presentation.
Thank you, Andy.
We are very honored and learning to hear you, ma'am.
Thank you, Andy. And thank you. It's a very boring presentation. I think it's
No,
like
no,
a
ma'am.
pharma
It was a very good presentation. Actually, I can say because we have seen there is an intense research aimed at understanding it, PCOS and its treatment. But definitely, this is like I have some potential benefits in management of PCOS.
Yeah, provided it becomes cheaper.
Yes, ma'am. Yeah. So, ma'am, if you allow me, then we'll take the questions, ma'am.
Yeah, please.
Sure, ma'am.
Just give me 2 minutes, please.
Okay, ma'am. No issues.
Hello?
Yes, ma'am. We can hear you, ma'am.
Yeah, please.
Yeah. Ma'am, we have a first question that is, how safe is this lid? I think they want to say this.
Liraglutide.
Yes, liraglutide.
Liraglutide.
Yeah.
Actually, there are studies telling the dropout rate is more. But frankly telling, even like I've spoken to many endocrinologists, even the busy practicing endocrinologists, so they have told that we have not used it much, mainly because sometimes because it's not cost effective. So frankly telling, I have not used it. Not the endocrinologist, 2-3 endocrinologists whom I have spoken, they have used it. But I've seen the many Google reviews, and the reviews are good. Like they are telling we have lost weight, especially it is used in US, and they are the reviews are telling they have lost weight.
Yeah. Thank you, ma'am.
Yes, sir.
We have one more question, ma'am.
Yes, sir.
How similar this GLP-1s when compared to human GLP?
They are quite similar. That's why they mimic the GLP action. So they are quite similar. That's why they are called mimetics.
Thank you, ma'am.
Thank you, sir.
Ma'am, we have one more question. That
Yes,
is,
sir.
how much folic acid is should be given post bariatric surgery or in normal women PCOS planning for pregnancy?
We usually give that 5 mg folic acid tablets, sir, which is available. In women who have undergone bariatric surgery, only folic acid supplementation is not sufficient. She has to undergo a lot of supplementation, multivitamin supplementation, Along with, and she has to, some women even require antidepressants because there are chances of high rates of depression in women who have undergone bariatric. So bariatric surgery, it is a group, it's a team effect requiring the what you call the surgeon and the dietitian, and also it requires psychiatric, even a psychiatric is also needed because there are high chances of depression in these women.
Thank you, ma'am.
Thank you, sir.
I think there is one more question from Dr. Hari, asking that is there any role of incretins in adults and PCOS?
So as such, they have one or two, like, if the children are above 62 kgs, it can be used, but we don't know the safety profile of it. But studies suggest if the children are above 62 kgs, it can be used.
Thank you, ma'am.
Thank you, sir.
I think there are no more questions from the delegates, ma'am.
Yes, sir.
If you allow me, then we can close this webinar.
Yeah, and I'm please excuse me. It's the first time I'm talking about a topic about a drug which I have not used personally.
No issues, ma'am, because this is actually a new topic. Because even we have seen a lot of topics, but when it comes to this, this is like actually a upcoming topic, I can say.
Maybe next 5 years, after 5 years, maybe we'll have more data.
Yes,
Because
yes.
it's not gynecologist alone, it's like even endocrinologist, they are very clear about incretin mimetics. We have not used much, whereas DPP4, they are like we use quite commonly, but it does not, it just helps in weight maintenance and it does not help in weight reduction as such.
Yes, yes, ma'am. Even there are more and more GLP 1 hour coming into the research. I can see that, and I think maybe as you said in the future,
Yeah.
this could be a talk.
Yeah,
Right?
and like I searched something like whether there are any dietary supplements which mimic incretins or they increase incretin production. So I came across a few interesting things like, the bitter gourd, the Karela, it increases incretin production. Even the cinnamon stick up to 3 gram, it increases incretin secretion. Mango leaves, the raw mango leaves, it increases incretin secretion. So maybe we can advise our patients like the commonly used household remedies also, like the cinnamon stick 3 grams and even bitter gourd, 1 bitter gourd juice daily if they can.
Yeah, it's very nice to know, ma'am. It's very informative actually. So thank you very much, ma'am.
Yeah, thank you.
We are very honored to have you, ma'am,
Thank
and we
you. Thank you.
look forward for your continuous support
Yeah,
for
thank
the
you.
educational activity.
Thank
So
you.
thank you very much, ma'am, and
Thank
many
you.
thanks from the Shield
Yeah,
team.
thank you. Bye.
Yeah. And I also thank all the delegates for the active participation.